Okay, so it's 3 o'clock. We can get started because we have a full program. Uh, Good afternoon. So it's time for the keynote presentation. It's a pleasure to introduce Franca Poppi, who's full professor of English language and translation at the University of Modena at Reggio Emilia. She also serves the director of the University Language Center and scientific director of the Gonzaga School of Linguistic Mediation in Mantua. Her work brings together discourse analysis, corpus linguistics, with a focus on English as a lingua franca. And she's joined by Judith Turnbull, associate professor of English language and linguistics at the same institution. And her research is situated in applied discourse analysis and corpus linguistics. And they'll be speaking on a highly relevant issue, the presentation, which is entitled Health Communication in the Digital Age, from Websites to AI Doctor. The floor is yours.
Good afternoon, everybody, and thanks for being here. Now, as a first thing, as already announced by our chair, we're going to focus on health communication. In particular, we are going to focus on how information is translated, mediated, as we go from websites to AI doctors. Unfortunately, we will focus most of our presentation on websites because that's where we started from, and we will only consider AI doctors in the final part of our presentation. I said unfortunately because, as a matter of fact, while we were looking at our data, we realized that it would have been very interesting to devote more time also to AI chatbots. But unfortunately, okay, as already stated, that's the way we decided to organize it. Now, let me just say a few things about health communication and how information about health has been conveyed through time. So at the beginning, we had printed material, posters, leaflets, and of course, these written materials contained strong visual rhetoric, but very simple and directive messages and broad kind of information. Then we had institutional brochures and oral communication, that is, patients support group by telephone and also face-to-face meetings. With the advent of the digital age and the digital platforms, we have seen the development of websites, blogs, forums, social media, with an increase in the explanation depth and also in the possibility of peer-to-peer exchange of information. Finally, nowadays, we have apps, telemedicine, and AI-driven systems. In a way, we have shifted from the provision of information in a way to the provision of services. Now, here, okay, our colleagues, Professor Bondi, Professor Tessuto, have already provided you with a wealth of information about knowledge dissemination. Now, of course, what we are doing here is we are looking at health communication as a very special form of knowledge dissemination. Why very special form? Because, of course, as we will see also in health communication, we have different types of target audiences, but we also have an added element, a hybrid element to take into account, the chronic patient, because the chronic patient is halfway between the layperson and the expert. So it is a very, health communication exceeds in a way the borders of standard popularization, and it is extremely important to select the information in a strategic way to target particular audiences. Of course, here, as elsewhere, we have a selective reformulation and recontextualization according to Calsamiglia, Van Dyke, Capuscio, Gotti, and Garzone. Now, so basically, what we are trying to investigate, what we tried to investigate is how knowledge is reformulated as we go from websites to AI chatbots. And we will investigate simplification from the point of view of lexis and syntax, changes also in explanation and in interpersonal stance, especially this, because we will particularly, well, what emerged from our results is that there is a certain peculiar quality to the relationship between the target audience and the expert, the source of knowledge. And of course, we will see that in digital environments, there is an added dynamism. Now, what are the purposes of knowledge dissemination? We have expert to expert, expert to novice. I mean, people who are, for instance, as our colleague this morning, Kristen Kirsch, she said she's studying now medicine. Okay, so we have also novices, people who want to become professionals in a certain discipline. And also we have public-oriented dissemination. But as I already told you, in the case of health communication, there's an added element of change or this hybrid role of the patient, because yes, we said very often patients are well versed in the discipline. Well, they know a lot about their problem. Well, they have to, if they want to live a reasonably normal kind of life. And if they want to balance, for instance, knowledge about the things which are good or bad for them and their normal life. Now, as we go from websites to AI doctors, we will notice that there's a shift from a kind of top-down to interactive models of communication. Of course, AI promises scalability and personalization. This is an important element, but it also raises ethical concerns concerning transparency, accountability, and trust. As my colleague will show you, actually, trust is a very important element. Now, the case study, because I haven't yet uncovered what our study was devoted to, we choose diabetes as a case study. Why did we choose diabetes? Well, first of all, it is a chronic illness which demands long-term engagement on the part of the patient, who has to learn a lot in order to balance his or her lifestyle with his or her condition. And it requires a certain behavioral change, of course. And in addition to this, another reason why we decided to focus our study on diabetes is because my colleague 10 years ago researched diabetes and the same websites that we are now taking into account today. And so we wanted to provide also a kind of diachronic perspective. Now, just 2 words on how information about diabetes has been disseminated through time. At first, there was what is defined as DSME, Diabetes Self-Management Education, and it looked like it was quite effective, since evidence reports of improvements in patients' conditions. But after this, okay, we are now going towards a different kind of dissemination, a dissemination which also aims not only at passive knowledge transfer, but at patient or target audience empowerment.
So if we're thinking about communication online, we have obviously immediate benefits are that you can outstretch to large numbers of people. Much more than a pamphlet or a brochure can reach, immediately you reach a large number of people. There are various affordances available which give opportunities to present information in various forms, but there is a number of downsides about online communication. As we all know, that when you look for some information on the internet, you have a whole range of websites to look at. The information can be overwhelming. Even worse, it can be actually conflicting, confusing. One-to-many communication it means that we have an undefined public with no common no common level of shared knowledge, and we don't have a discourse community as such. So we're going to have people with different backgrounds, levels of education, and this obviously creates problems in calibrating the information at a correct level, at a level which is simple enough to be effective, but without going beyond that and actually dumbing down, because there's nothing worse than reading information which treats you as if you were a 2-year-old, I think. We all have that reaction. As an internet, as a website is a very complicated organization, the layout of it, we have access to links, we have hypertext, we have videos, and all this means that we have to be multiliterate. The actual fact of consulting a website is not a passive action. You have to be active. You have to learn to be multiliterate. If we're talking about health communication, we're thinking about the strategies and the information which is being passed from the expert to the layperson. The other side of the coin is the question of health literacy, which the World Health Organization has defined as being able to access, understand, appraise, and use information and services in a way that promote and maintain good health and well-being. It's not just a question of being able to read, have access, and whatever. You have to be able to act upon that information. So health literacy is a question of empowering people. That's fundamental. In 2013, which is reported by Sorensen et al. In 2015, the World Health Organization did a survey on the level of health literacy in Europe. And the outcome was, on average, 47%, nearly half the population has limited health literacy. 10 years have gone by, but I doubt whether it has improved very much, especially as on one of the websites that we were looking at, there was a video with interviews of people in, I can't remember if it was Birmingham or Nottingham, a city in Britain, and they were interviewing people about diabetes. There were people who had some kind of knowledge, some people had no knowledge, and some people, perhaps worse still, had wrong information. So this is a very serious question which has to be considered when presenting the information and targeting certain audiences. So as we've heard before this morning and also now, Franca would mention the case that health information requires simplification that remodels the language and the content. And health information is similar in many ways to popularization, but I think we have to make a distinction, a very important distinction between popularization and health information, which I would refer to as empowerment. Popularization informs the public to broaden their knowledge if we think about climate change. But what I know about climate change isn't really going to affect my life directly. If I learn about health and health condition problems, then that can have a beneficial effect on my life. It's this difference between factual knowledge. It's not just about factual knowledge, but it's also to do with persuading the reader to follow certain treatments, accept his condition, or change his lifestyle. And Schulz and Rubinelli refer to this kind of argumentation as info-suasive, which, as the name suggests, is a combination of information and persuasion. And in this, the important elements to consider are empathy, credibility, and trust. The corpora that the data that we collected was from 3 websites, British websites. As you can see from the number of words, the corpora are fairly small. We didn't do a quantitative analysis, it was purely qualitative. The patient info website is managed by doctors. It's a website which deals with many different health questions, but has many pages dedicated to diabetes. The other two are specialized in, as the names of the website suggests. The diabetes.org is a registered charity, and it works to raise awareness of diabetes as well as supporting people who have diabetes. They fund and promote research. And interestingly, it was founded way back in 1934 by H.G. Wells, who was himself a diabetic. Diabetes.co is instead a community website, and the information is provided by diabetes experts, but there is also quite a lot of diabetics who actually contribute to the website. These different origins are actually very important in the way that the health communication takes place on these different websites. We used the same theoretical framework that I used 10 years ago. Many of these we've already touched upon today, so I won't say very much. The cognitive dimension I must say that the denomination and definition are used very frequently because of the need to introduce the medical terminology for the patient to be able to communicate and understand clearly in the medical context in order to cope, to manage their condition. Exemplification, scenario, metaphorical language are all forms of concretization. That is bringing abstract knowledge into relating it to everyday life and becoming more concrete, less abstract. The communicative dimensions we too have drawn on Highland and Giannone, although they were working in a completely different field, but proximity and engagement are obviously relevant in this context. Adolphs was actually working in a healthcare setting. And now I will move to the analysis.
Yes, let us have a look at the results, at the first results of our analysis. Okay, so we focused first on cognitive strategies, which are in a way the easiest one to identify. Okay, one thing, in accordance with what Chapuscio and Gulick state, we also notice that these strategies do not occur in isolation, but they tend to occur in clusters, sequences of strategies. Now we will look at each the predominant strategies in each of the three websites, and then we will have a kind of summative table to sum up the results and compare the results which emerge from the three websites. Now, in patient.info, which, as my colleague has already underlined, is managed by doctors, we see a prevalence of the sequence denomination, definition, description. Okay, so we have the name of the disease, and then we have explanations, which are further followed by also definitions and descriptions. Now, another cluster of strategies which frequently occurs in patient.info is to have denomination, definition, description, and then scenario. What is the function of scenario? Okay, it is to ground the experience to the problem, the symptom to everyday facts. Okay, here, for instance, you have if blood glucose remains high over time, complications may develop. So you may have an impact, a negative one, in your daily life. So here, what is the function? To construct this biomedical information and understanding in a patient's everyday life. But as you see here, we only talk about complications, not actually something more concrete than that. Okay, here, okay, again, we have this reference to complication. And then, we also have instances of concretization. That is, for most people, this means they are talking about levels, okay? So this means aiming for levels between 4 and 7 before meals. And then also, without treatment, you may become dehydrated and lapse into a coma. Okay, so this is an operationalization of possible consequences. But as you can see, it is not exceedingly, supportive, because, yeah, a coma, the perspective of a coma is not, of course, a very nice one. Now, this is diabetes.org, which is a charity. Okay, here we often have definition, which is followed by reformulation. So let us say that in this website, differently from the other one, there is a more pronounced effort towards reaching out to the audiences. While in the other one, as we will see, there's a more authoritative stance, since it is managed by doctors. Here we have this effort to reach out to people. And actually also here you have scenarios, exemplifications, going to the toilet a lot. This is something very much down to the ground, being really thirsty, feeling more tired than usual. Okay, and you can see here, rather than talking about lapsing into a coma, it can make you really ill really quickly. So here we have a reduction of the epistemic distance between the source of information and, of course, the audience. This is the last one, which is actually a community of people with diabetes. And here we also have the use of metaphorical language. But also, as our body produces the hormone insulin to utilize glucose as fuel, or store it for later use, fuel. So, okay, something very concrete. Now, this is another sequence of strategies that we can find in diabetes.com. We have very often, as you can see, while in the first type we mainly had definition, denomination, definition, description, we also had scenarios, but they were not as concrete or down to the earth as this one, you see? And here very often there is the information, and also the disease is reframed experientially. Now, let us sum up the information that we gathered from the analysis of the 3 websites. So in patients.info, denomination, definition, description, we have dense biomedical explanation. And as we said earlier on, we have this stance of authority, precision, and there is a high cognitive load. Diabetes.org, we have very often reformulation, frequent exemplification, and the overall effect, as I already told you, is this of a reduced epistemic distance, and there is this idea of the patient, the reader, being guided gently without, menacing, terrible scenarios being evoked. Finally, diabetes.co, actually we tend to talk about the 3 websites in this order, and this is not a case, because we just want to highlight the fact that as we go from one to the other, the epistemic distance is reduced. Also here we have a metaphor and a concretization, which are foregrounded, and here there is less emphasis on this high cognitive load, and the overall effect is one of engagement, motivation, and practical impact. What kind of takeaway can we gather from the analysis of these results? All 3 share a core explanatory toolkit. Description, exemplification, scenario building are very, very used in all the 3 websites. So what's the difference? The difference lies not in the kind of information which is conveyed, but in the distinct epistemic model. So in the kind of strategies which are employed, and depending on the cluster of strategies which are employed, we can clearly see a different epistemic model of the source of information layperson relationship.
Okay, so now we'll pass on to the communicative strategies. And as we said before, trust is a fundamental element in health in communication. And to build that trust, the sources must show their credibility, their authoritativeness. They have to establish a positive relationship with the reader. And as what I'm going to do in this part with looking at the communicative strategies, I'm going to look at the various strategies, the rhetorical functions of the various strategies that are used to achieve this positive relationship and credibility. The question, as Franca was just saying, this epistemic model of expert to layperson communication influences greatly the way that they use the communicative strategies. So starting with personalization, obviously, if you want to establish a positive relationship, you have to enter into contact, so to speak, with the reader. The pronoun you, as you can see in the the second example, you can find out your risk with our Know Your Risk tool, which I must say I was tempted to actually try myself and see whether I am at risk of diabetes. Directly addressing the reader, obviously. The example at the bottom is you again. When you've got type 1 diabetes, you can make any insulin at all. If you've got type 2 diabetes, it's not directly, obviously, the you is not directly addressing the reader, but here we have a generic you, which creates a more friendly, informal atmosphere, which can contribute to the positive relationship. The first example, if you show signs of having diabetes, your doctor may use blood or whatever. This was actually addressing directly the reader, but this could be also out of context. You could take it as a generic you. So this use of you is quite often a little bit blurred in various parts of the text. Thinking about creating this positive relationship, we obviously have inclusive we. The problem of coping with the condition of diabetes is very complicated. People are not always successful. So here, having a diagnosis of type 1 diabetes is usually a big shock. And some of us wonder how we're going to cope with the condition. Here, the we is saying that you've got a sense of belonging. You're not the only one with this condition, with these problems, with this reaction of shock or whatever. Some of us, many of us, or possible, everybody reacts in their own way. And the second example is about talking about when they lose control of diabetes, and there again wants this idea of solidarity. You're not alone. It happens to everybody sooner or later. Well, after the inclusive we move to the exclusive we. Here, this is to establish credibility, authoritativeness. Here, they are from the two diabetes websites. In the first case, we have the bodies naturally goes on. In the second line, it goes, with this in mind, we've compiled some tips. And this is the community website, which is, yes, they are the experts. They're in a position to able to actually compile these tips, and we're passing them on to you. And very collaborative profile, let's say. The second one is the charity organization, and showing a little bit more of the scientific, the medical expertise. We don't know the exact cause of type 1 diabetes, and scientists think so, obviously drawing attention to the fact that they are following research as it goes on. They're promoting research itself. And so that there again, obviously they are the experts and showing it to the public. Patient info also has very similar expressions, referring to research, discussing the question of what's the cause of type 1. So far, I've looked at personalization, but we also have the opposite. We have depersonalization in quite frequently. I've called it here diffusing a problem, because obviously there are numerous problems involved in dealing with diabetes. And here it's trying to not just rationalize, but try to not to stop the person from feeling responsible or feeling guilty for not being able to control their diabetes. And how do they do it? Well, first of all, your control, we've got a nominalization. It's not that you're controlling, you didn't control. Your control has let you down. They are become a victim themselves of the control that went wrong. It can help to spend some more time. So they are trying to, yes, it happens. It's not your fault. Don't feel guilty. It may feel like hard work. It gives advice on how to deal with it. It may feel like hard work, but it's really helpful. So a little bit of encouragement. And also in the second example here, where we actually have how do I treat hypoglycemia? This was part of the section of the website. It wasn't from the forum or anything. And here it says a mild case of hypoglycemia, not if you have, but it's totally impersonal. And it gives the example with the passive form, so therefore depersonalizing. However, depersonalization is not just to help people face the problems that they have, but in the case of patient info, the doctor's website, it actually characterizes the whole website and the style. It talks about it's very important for people with diabetes. So they're put in as a category apart, people with diabetes. It's an expression which is repeated numerous times, which I found it as rather alienating in a certain way. The others websites did use it, but not in the same to the same extent and not in the same way. The last example I also found rather alienating. If blood sugar glucose levels are not well controlled, this may cause a lack of fluid in the body. So the body becomes an object. It doesn't belong to anybody. It's there. It's a matter of scientific medical interest. So I would say depersonalization taken to the extreme. The other point that I want to look at is when you're giving advice. So this first part was more about the information. Here is giving advice or worrying information. And here we have examples of the use of modals. You should, you may find it useful, this may progress. These are using the modals sort of mitigates to a certain point the force of what is being said. Here I've called it conveying politeness because it's a way, once again, of giving advice, but we know that giving advice in the Western context is face-threatening. And so to try not say what you have to do, but give suggestions, put it forward as a possibility. It's up to you to decide whether or not, but they clearly say that it's a good idea, it's important, giving gentle encouragement. We also have eating a healthy, balanced diet, being physically active. Here we have nominalization, and therefore no person is actually involved that you have to eat healthily or whatever. Humor. Well, you didn't find any humor. I surprisingly found 2 examples, or perhaps 1 or 2 more even. But it's a pain for all of us. Injections are a pain for all of us. Trying to encourage people. Some people have a terrible fear of injections, of needles, and as a diabetic, you have to get used to them. And so a pain for us playing on this idiomatic expression. The second one surprisingly came from patient info. saying a hypo is usually defined as blood glucose below LMol. A useful way to remember is 5, don't drive. 4 is the floor. Which is a rather strange thing for doctors to, in the context of this website, I find it rather strange. But then, I don't know, it's up to everybody to decide, but then it goes on to explain what it means, which seems to me, it sort of tends towards a little bit of dumbing down. You know, if you haven't understood the joke, I'll explain it to you. Metaphors and marked lexis. Here, marked lexis, I don't actually mean emotional or strongly evaluative. Marked lexis here I've taken as colloquialisms, informal language, and metaphors. As you can see here, I have a list of 4 examples of metaphors. The metaphors themselves are they're not cognitive metaphors. They're metaphors which are used in everyday language. It stops diabetes in its tracks, it being in tune with your body. It's everyday language, therefore it's this kind of very friendly atmosphere that they are trying to create. Comparative takeaway. Here it's a little bit more difficult to actually categorize them because all 3 websites use all the strategies that are available. They use them in different ways to different extents. Even in patient info used you, but in the generic you. But they all, in their own way, managed to establish a positive relationship and to establish credibility, thus creating trust. But where the difference lies is we're going back to this epistemic model of expert-layperson relationship. This positive relationship, what kind of positive relationship? In the case of patient info, you have this, these are extracts from talking about the same problem, HbA1c, which is a particular type of blood test. If you have diabetes, your doctor or nurse may test your HbA1c levels. So it's the doctor, the nurse, who's telling you that when to do it and if to do it. In the diabetes.org, here they say what it is. What is HbA1c? It gives the definition, the levels that you should have, and then it goes on to explain how they are going to explain it in greater detail as you go on. So they are guiding you through the website. And the last website, the community website, gives the same information, perhaps a little bit more detailed, really helps the person, the patient, understand what it is. And they use the word clinicians, which are obviously referring to nurses and doctors, but they use it, clinicians in general, not your nurse and doctor who are telling you what to do, but by measuring glycated hemoglobin, clinicians are able to get an overall picture of what our average blood sugar levels are. So we're working together, the doctors, the clinicians, with the patient, and it seems a much more positive approach. And now back to
Now, so why did we decide, after having looked at websites, to shift our attention to AI? Now, well, first of all, let me state that websites are still a stable reference for patient. And I would like you to remember the adjective stable, because as we will see, actually, while AI is characterized by a certain dynamism, websites tend to be a little bit more static in their replies, of course, because of their own nature. Now, why did we decide to shift to AI? Well, lately, AI has, of course, been the object of many studies, and for instance, Ayers and others have investigated a series of questions which were posted on chatbots, and then the same questions were answered by doctors, and still the same question were answered by doctors who revised the answer produced by AI. And it looks like, well, they remarked that they found out that actually patients liked the question produced by AI but revised by doctors the best. Okay, and in addition to this, Ayers and others also rated a high degree of empathy and, of course, also quality in the responses provided by AI, sometimes even higher than in the responses provided by doctors. In one case, we had, I'm sorry to hear that you got a beach splashed in your eye. Okay, so that's what AI replied to the query posted by a person who said, oh yes, I splashed bleach in my eye, what can I do, and so on. Now, Ayers and others conducted their study in 2022, and they used ChatGPT 3.5. Okay, of course, there have been other studies which looked at the chatbot and health communication, and the results, for instance, Golan and others, they drew the conclusion that AI provides very personalized explanation. Also, Sun and Joe established that chatbots are particularly good at establishing this dialogic relationship and also at personalizing information. Finally, Wu and others focused on diabetes. They carried out a kind of survey of 25 studies that have been published on AI in connection with the health communication, and they concluded that, of course, people need like this kind of personalization, sorry, and this kind of dialogic interaction that they are able to establish with the chatbots and, of course, not with the websites, for instance. So what did we do? We choose from the forums of each of the three websites 10 questions, and then we posed these 10 questions as queries to a special platform which is based on ChatGPT, but a specialized version of ChatGPT. As a matter of fact, we went to the address https://cureai.co.uk, and then we got a list of various topics connected with health communication, and we used the one which was reserved to general practitioners. Now, what emerged from our analysis that, of course, we were using ChatGPT, a dedicated version of ChatGPT, but it's ChatGPT nonetheless. So, schematic organization of the responses, frequent use, of course, bullet points, okay, frequent use of headings, numbered sections, okay, and the information is broken down into discrete units. For what concerns cognitive strategies, no major difference with what website did, okay? Also here we had definition, description, metaphors, scenarios, but everything was embedded within this bullet pointed structure. We also had personalization, politeness, inclusive, especially there is this idea of trying to establish a dialogue. Let's break this down carefully. There's also conditional advice, and there is the avoidance of an authoritarian stance. Now, what was the main result of our analysis? Different from Ayers and others, we did not come across any real instances of emotional empathy. What we found is what we called interactional alignment and situational empathy. What is it? I mean, we have normalization, trying to make things normal. Diabetes burnout is common and normal. It's not a failure. Face saving, this doesn't mean you are failing. So you see, there is this interactional alignment. So the chatbot is trying to support the people, but without any emotional, even though we were discussing with colleagues colleagues earlier on, of course, if there is emotional empathy, it is, of course, fade, but nonetheless, it is not there. So in our quest for emotional empathy, we devised another question number 11, which was not contained in the forum, but which we devised ourselves, and we made it particular. We tried to phrase it in such a way which, in our opinion, should have elicited a bit of empathy. Not, I'm sorry, but I don't know, something like this. So I'm feeling very thirsty, I have to pee a lot, and I'm very tired. Do you think I may have diabetes? So we expected reassurance from the chatbot. Yeah, we did. Well, actually, the chatbot replied, well, this condition, your what you are feeling may be due to diabetes, but also to a series of other conditions. So actually, we didn't get much empathy there either. So what can we say about the various websites and so on?
So, as it's already emerged from what we've been saying, I think the different epistemic model of expert-layperson relationship distinguishes the different websites. We don't want to make any judgment on which is better, because we don't think it's a question of one being better than the other. I think it's a question of personal choice. Some people may prefer a more traditional type of doctor-patient relationship, so they may be happy with patient info. The others may be more suitable. I think it depends very much on the individual. The question of websites, we haven't actually dealt with the multimodal aspects of the websites, because that is a whole another world to investigate. But the fact that there are different affordances available, already a website in itself is like a maze, like a labyrinth. You go around in one place, you get to an end, and then you go back, or you find yourself in a different part. So it's difficult to navigate, and that must influence to a certain point. You get a broad range of information, but it's static. By static, we're actually meaning it's fixed, it's there. You get it, and that's it. Whereas with AI, it's easy to navigate, and it certainly requires care in formulating the prompt, but it's the beginning. When you start, it's the beginning of a kind of interaction. You can open a kind of dialogue of a kind. You add another prompt and you get another answer. It also, at the end, suggests, do you want me to do something, give you a chart or whatever? So it's an ongoing dialogue. You can, if you're good at it, you can formulate the question in such a way that you get the exact information that you're looking, but I don't think it's as simple as it may seem. And then there's the question that you may get information which is, you think, I'll take it as being true, but who knows whether it is actually true. The lack of emotional empathy is, as Franca was saying, contrary to the expectations based on previous studies. But I also must say, well, do I really want the empathy of a machine? The last point, we come to the conclusion that yes, AI has a certain role to play. We may consider it to complement rather than replace websites, which would be perhaps the starting point for finding out about diabetes or other health conditions. And
that's the end of our turn. Thank you.
Thank you very much for the outstanding presentation. I think we're going to have the discussion at the end, of the session. So I'd like to call Dr. Russo right now. Right, so Dr. Michele Russo is a resident in the anesthesiology program at the University of Parma. Okay, he's going to present the new technologies and vital signs in perioperative medicine presentation.
Good morning, everyone. As you can see, I'm not Elena Bignami, but she told me to cheer everyone. She is very sorry for not being here. And I have no conflict of interest. And the first question is why innovation matters. And this is the first question that we should put in our field. And the answer is to improve our patients' outcomes, to improve efficiency, to manage complex situations, and doing that with excellence and sustainability. And those are the new technologies in anesthesia and resuscitation. And let's start with predictive and generative AI. Those are the key AI technologies in healthcare. As you can see, the first one are predictive. We have to discriminate between predictive and adaptive AI, which is kind of different. And then we use generative AI, for example, for creating new content, including medical documentation and chatbot-based patient interactions. And also, we have to differentiate between the black box and explainable AI, which the last one, of course, can build trust by making AI-based decision. Then we have machine learning, which is a subcategory of AI that allows system to learn from data without explicit programming. It is classified into three types, which are supervised learning, which are algorithms that learn from labeled datasets, unsupervised, which are systems that identifies patterns in data without pre-existing labels, and reinforcement learning, which is AI that learns optimization throughout trial and errors. Okay. Actually, we are living in a scenario of high complexity, and but with a fragmentation of data, with information overload, but from the other side we have manual operations, and we have the need for interoperability for timely decisions. Okay, in this case, a balanced approach that includes collaboration with various stakeholders, including policymakers, healthcare providers, and technology companies, is the key to success in driving meaningful change in digital healthcare adoption. Imagine our roadmap as a ladder where we should identify primary elements, innovations, challenges, and potential solutions for the adoption. Okay. Sorry. Okay. New technologies, from device interoperability to clinical AI systems, are not a goal in themselves, but an essential means to achieve our modern vision of anesthesia and intensive care. As outlined from this consensus, anesthesiologists should be data-driven, with the main they have to oversee networks of interconnected devices, interprets aggregated data from ventilators, pumps, smart beds, electronic health records, and makes decision guided by validated clinical AI. So I want to emphasize that artificial intelligence is only effective if data is interoperable, and for this we need data quality, we need algorithm transparency, and model generalizability. Unfortunately, operating theater is an extraordinarily complex system. The complexity is manifested not only in the patient and their condition, but also in the sophisticated instrumentation, in the high volume of information to process, and in the nature of communication and coordination. This complexity, combined with heavy workloads, fatigue, and production pressures, makes surgical care particularly vulnerable. As you can see, in fact, in this recent systematic review, despite the limited quantity of studies and their heterogeneity, organizational factor appears to be to play a significant role in surgical outcomes. We as well conducted two systematic review of literature on the argument, and our results showed how AI can be successfully used in operating room for three different goals, in particular prediction of surgical duration, post-anesthesia care unit length of stay, and risk of cancellation of operations. And this is our hybrid model that we proposed, where human intelligence is combined with artificial intelligence, and together we use them to reach our goals in patient care. This is a slide where we can find various AI tools and system, their functions, and the area of application. For example, we have hemodynamic prediction with the hypotension prediction index, HPI, that predict intraoperative hypotension. We use analgesia monitoring. You know how difficult it is to objectivize pain. More when the patient is asleep, and we use closed loop drug delivery systems and the EEG interpretation for advanced sedation and to know the depth of sedation. Okay. This is bibliometric analysis. The number of publications has increased annually since 2018, and with the most significant contributors, USA, China, and England. The research application of AI in predicting hypotension has been extensive and represents our spot and a frontier. Of course, as you can see, there are promises like improved patient safety and complication prediction, personalized perioperative care, but we have also perils, in particular algorithmic bias and inequity, black box opacity, automation complacency, and over-reliance, and unreliable recommendation, also liability and legal uncertainty. Of course, there is the need for control and transparent models, and this is the European Artificial Intelligence Act. This is the first act to at least explore part of those problems, and the system divide the risk in unacceptable, high, and moderate or limited risk, with corresponding regulation and assessment. And this is also the ethics and governance for healthcare. Okay, but for AI there are also other problems, like poor data quality and lack of educational programs, especially for anesthesiologists or medical doctors, and legal and ethical problems that, as you can see, can contribute to create a lethal diamond. From the concept of garbage in and garbage out, we switched to the concept of proactive digging in and diamonds out paradigm that cultivate excellence and for AI implementation, ensuring AI system enhance and augment rather than undermine healthcare delivery. As previously mentioned, I want to stress the importance of human training in AI. And now let's move to new technology applied to ICU. This is a smart bed, as you can see, that can provide us with continuous monitoring of position of the patient, the weight, the size, and the brakes. Is integrated via Wi-Fi, and of course is connected with the dashboard to our systems. I cannot stress enough the value of structured data compared to manual data. And here you can see the difference between the continuous monitoring and the traditional workflow that we had. That being said, existing models offer many valid solutions, but none of them can solve all the challenges on their own. Real-world clinical application require not only accuracy, but also reliability, interpretability, timeliness, and compliance with ethical and regulatory constraints. And in this study, we can see how we can use big data to build an hybrid model to support healthcare workers. In this other study, we can see how properly integrating informative laboratory data into predictive models to improve the external validity of models, to reduce systematic biases, provide more realistic risk estimates, and allows for better exploitation of the temporal richness of our electronic health records. The typical application could be the prediction of hospital mortality or post-operative complications, dynamic monitoring of patient intensive care, early warning models for clinical deterioration. And here an example of how we could apply to each AI to each phase of perioperative path. As you can see, we can use AI for the perioperative evaluation, and also we can use AI in surgical wards with telemetry. In the operating room and recovery room, we can monitoring in continuous vital signs and record that in medical record, which allows us to have a prediction in real time. And then after the discharge from the operating sector, we can use AI in ICU or in the surgical ward again. In this table, there is a summary of all new technologies that we can use in perioperative medicine, not only AI. And here a study that applied AI for mechanical ventilation, for recommendation personalized on the patient for ventilatory settings with a good outcome. Is a closed-loop technology. We can use also AI for antibiotics. In this picture is shown how the physician had the opportunity to reassess the antibiotic therapy 48 hours before earlier than antibiogram results. We can use AI also for acute kidney injuries, and this is the only validated, external validated AI. It is on the market, and it predicts the outcome of acute kidney injury in ICU, and also the requirement of dialysis. We can use AI also for pressure injuries. And in this case, this AI used advanced analysis of medical records and allows us to have operational efficiency, and it is superior compared to traditional methods. In our mind, the system should have modularity and scalability. And this table demonstrates the measurable impact of interoperability. And again, now I would like to introduce you to Miss ICU, which is our AI agent for use in intensive care unit that should perfectly integrate and help us in everyday practice. Okay. Those are the main characteristics we would like to implement in ICU. Predictive ICU, collaborative AI, voice interfaces, digital twin like Miss ICU, simulation, and interoperability. And thank you, and I hope to see you all at Parma next year. We had in January, the last January, a meeting on AI, anesthesia, medicine, but with a lot of engineers and other figures, so welcome. Thank you.
Thank you very much for your presentation.
Thank you.
I'd like to call back Professors Poppi and Turnbull, and we can open the presentations for discussion. Is there any question from the audience? Yes, there's one question.
Just one question, just out of curiosity and asking for some kind of clarification to you, Judith or Franca. I was just wondering whether your data, your website, include, I mean, when it comes to this diabetes website, yeah, I mean, does your data website involve integrated or coordinated medical care plans for people suffering from, you know, diabetic conditions? Possibly going into interdisciplinary care plans?
Oh, there was no, it was purely
It's just personalized?
Nothing so specific as that. It was general information, fairly detailed about the various possible complications with it, but there wasn't anything of that kind.
No, also because thank you very much. This is a good question because you allow us to give us the possibility of explaining something about the data we collected. Since we looked at 3 different websites, okay, so we concentrated our analysis on the comparable sections which appeared in all the 3 websites. So basically, we concentrated on an overview of diabetes and then on type 1 and 2.
The treatment, the possible medication, and the lifestyle, diet, and this sort of thing that.
Okay, because these sections appeared in all the 3 websites.
No, because that actually was flowing to my mind because as far as I know, interdisciplinary care plans are very much popular in the UK. Interdisciplinary care plans. So, I mean, when it comes to diabetes, why not having, I mean, my question, I mean, you know, things that I'm asking myself,
to specify
why not having interdisciplinary care plans for diabetes?
Level.
Sorry?
We only went to the first level of the website because it was so extensive. Because clicking on the menu for, I don't know, type 1 but diabetes, then we got a menu of about 8-10 sections. So rather than going and clicking and going further, it would have become.
And also, as far as I know, diabetes, I mean, people suffering from that kind of conditions, diabetes, are usually referred to specialist primary care services, yeah? So, I mean,
Well, they
there's a
have
kind of
nurses,
mixed
they have
up
dietitians who follow them.
treatment plans.
They have a group actually following them. Yeah.
Yeah, actually, that's why we talked about this hybrid quality of the patients.
You have another question?
Thank you. Obviously, as a persona interessata, I have to say, I was very interested in what you had to do. And I think years back, I did start looking at these websites. One thing, you were talking about expert to layperson. I'm just wondering, at a certain point, I don't now consider myself anymore, being a diabetic patient, to be a layperson, because I've gained a certain amount of experience in having the illness. What I think another sort of an offshoot and something that might be interesting to work on in our later research, other bits of research, would be the chat area. I remember seeing on these chat areas. Sorry, I'm not used to using microphones anymore. On these chat areas, you've got layperson to layperson, you've got diabetic patient to diabetic patient. Okay, moderated by an expert, but they are exchanging opinions, examples or experiences. And so you can then go into the language, we as diabetic patients. I mean, I think there are lots of things that can still be it's open for research in the future. And I haven't mentioned artificial intelligence. I don't see how you could have a moderator here to try and bring them together. I know.
Thank you very much.
Now, I have looked at the forums on the websites, and 10 years ago or so, I did actually work on the forums, but there is the ethical question. When I wanted to publish a paper based on the forums, and you have to ask permission to use the material, and they refused on the basis that you have to ask each individual user of the forum permission to use the data. There's no way. I said, well, even if and I don't put any names or anything, but they wouldn't accept it. I find this a very strange, a kind of contradiction, where nowadays everybody puts everything possible online. The forum is open to anybody. I didn't register with the forum, and yet you can't use it for research purposes. But yes, it's high. I don't think that they're not even, you can't even be defined as a novice. I think if you are a diabetic, you become an expert. As Gulick says, they become an expert of their own condition, because as I have learned that every person has their own diabetes and has to be administered in their own way. So yes.
Administer, not well, and so medication has to be administered, not given.
My question is also to Miss Professor Franca Poppi and Judith and Turnbull. In your opinion, what is the biggest risk you have to mitigate the universality of these websites? If I may respectfully give an example, if I type in about diabetes in English in Italy, where I come from, which is in Piacenza, I would highly be directed to an English-speaking website of the NHS. However, the guidelines and the units given are different. For example, the values given here were in millimoles per liter, but in the hospital of Piacenza, it's in milligrams per deciliter. So, which is probably why no one understood 4 is for you can drive and 5 on the floor, that idea. And also about glycated hemoglobin, the HbA1c, where I saw it was 6% here, and however, Italian guidelines use the American standard, which is 6.5, and this could create a large degree of confusion, in my opinion, among patients, because they'll be wondering, what is this? And because this is not very universal, and what would you say is the biggest challenge to mitigate this and create a more universal approach when we as future students design websites?
Well,
What is your advice?
the patients.info actually gave this information, made the there are comparative tables of the various measurements. I can remember in patient.info there was, I don't know, but I imagine that there is also in the others. I would have to investigate that. This is the risk, isn't it, of one-to-many communication, that you can have. You can search from Australia, you can search UK, you can search American websites. It's part of the risks, I think, of today.
But probably, I'm not sure I understood you correctly. When you were also talking about designing websites.
My idea was, what should we look forward to as probably a guideline or a key point, or what advice would you give to someone who, as a future physician or a journalist, who is looking forward to make a website and probably inform patients? What is there as a guideline or an advice you would give us?
Well, probably what she said, I mean, the presence of comparative tables, which, show both standards which are valid in different countries. Probably, yes, comparison, because, yeah, this is empower. I mean, knowing about this is in a way also empowerment.
I have a question for Dr. Russo. Your presentation was kind of intimidating for the breadth of this, spectrum of the possibilities that AI opens up in clinical medicine. But, how much of all, or how many of all these possibilities are actually already in use or can be translated into clinical medicine, and how much of all that is still far away in the future?
Okay, so for example, we have been using since many years closed loop. It calls TCI, which is targeted controlled infusion, which is a closed loop models, and it's trained on a lot of data from patients. We have a lot of models, each one for specific type of patients, obese patient, pediatrics, and we give it to the model the height and the weight of the patient. Okay, so we give to the model the height and the weight of the patient, and the pump is a syringe pump, start the infusion, and when it reach the level of sedation that we would like, it stopped, and it start again when the level is lower. So it's automatic. We have only to give the pump 8 weight and the concentration at the effector site that we would like. This is a very ancient model, but we use it. And then again, I talked about HPI, which is a hypotension predictive index. And we have one device, which is the only one on the market, so I can nominate it. It's Acumen from we have 2 models. One is completely non-invasive. It uses like a device on the end, and the other one, but of course, is less reliable. And then we have a mini-invasive one. We use to incannulate in certain patients the radial artery for continuous pressure monitoring. It's a default for us. Then we use that device, which gives us an alert 10 to 15 minutes before earlier an hypotension event. So then it's up to us to say why is it happening? It's the surgeon that is doing something wrong, or to try to know what are the problems, of course. But this is another type of artificial intelligence that we can use. So early warnings is very useful, and also another interesting field is the management of surgical lists. We have a trial in our hospital where we give the patient a bracelet that they wear from the surgical ward to the operating room, to the recovery room, and then outside. We monitoring the time, and with the data of the surgeon, the type of surgery, the type of patient, it gives us the list for the week. Yeah, but this is a trial, not commercial at the moment. Okay, thank you.
Just one last question. Perhaps I missed it, but how far, I mean, how large is your patient population regarding this artificial intelligence application? How large is your patient population?
So all commercial models are externally validated. It's not something that you can use with reliance in your hospital. So this is also a big problem because you need a lot of data, and as you can know, in Italy we have each hospital with a different electronic system. Also in the same region, so in Emilia Romagna, there are differences between Bologna, Parma, Piacenza, and so on and so forth. So those are all externally validated in other countries, and also in Italy. So we are able to apply them here for that reason. So it's a lot of patients, hundreds and hundreds of thousands. Okay.